It's my honor and my pleasure on behalf and in the name of the ISPM Directorate to welcome you to today's lecture within the Bern Lecture Series on Health Science. For the ones who might be here for the first time, the Bern Lecture Series on Health Science is a shared lecture series chaired by the Institute of Social and Preventive Medicine, the Bern Institute of Primary Care, and the Clinical Trials Unit. This year's lectures hosted by ISPM are also hosted by the Research Group on Community Health, and the 5 lectures all focus on participatory health research, and the different presenters will discuss participatory health research from different perspectives and fields of public health. And today it's my honor and my pleasure to welcome Dr. Claudia Hövener with us from Berlin, or even from a break from her vacation, and we are very happy to have you here today. You are a public health researcher with a focus on health inequalities and migrant health, as well as on research with marginalized and so-called hard to reach or hard to survey populations. And your focus of your work is on including participatory health research into epidemiological studies, which is quite of interest to our institute, the ISPM, as we have a strong focus on epidemiology. You've been working with the Robert Koch Institute, the National Public Health Institute in Germany, since 2010, first in the Department of Infectious Disease Epidemiology, and in 2017 you switched to the Department of Epidemiology and Health Monitoring. Since 2020, you have been leading the unit Social Determinants of Health at the Robert Koch Institute, but you also have been working with underserved populations in the past, and you are also a registered nurse in different hospital settings. So it's my pleasure to welcome you with us today, and the floor is all yours. We look forward to your presentation.
Thank you so much for that nice introduction. And I'm really looking forward to this talk today, because participatory approaches is something I really like to talk about, and something that I find as very important in health research. So I will share my screen now, and please let me know if there's something wrong with the connection, because I am not at the office and I know that it might be difficult. So just let me know if that's the case. We have a backup. So
yes, can I just, sorry, what I forgot to mention is if you have any questions as the audience throughout your talk, please feel free to note your questions down in the chat. Claudia will have one eye on the chat and integrate and try to respond to your questions throughout her talk. And we're going to have time to discuss your questions afterwards. But please go ahead. Thanks.
Okay, thank you so much. So first of all, before I start, I wanted to say that all this work that I'm presenting on today, I did not do myself, but there was a team of people of different research groups that participated, and I will talk a little bit more about that later. The title of my talk is Participatory Approaches in Epidemiological Research, and I will give some theoretical reflections and also some practical experiences. So today, oh, hold on. Okay, hold on a sec. For some reason, I cannot. Here we go. So the agenda for today is, first I will give you just a brief background about the research consortium Partcom Plus that a lot of you probably have heard about. Then I will give you a definition of what participatory epidemiology means to us. Us meaning in particular Mario Bach, Susanne Jordan, and also the research consortium Partcom Plus, where this definition was established. Then I will give you an example on how to include participatory approaches in epidemiological research with the study on sexual health in migrants from sub-Saharan Africa. I will point out quite a few challenges that we encountered and some lessons learned. And then lastly, I will give you, or I will reflect on challenges and benefits of participatory approaches in epidemiological research from different perspectives. So from peer researchers' perspectives, different stakeholders' perspectives. So that, again, I think is important, because whatever I reflect on might not be that important to others. Oh, hold on. I will close the chat. So the Research Consortium for Healthy Communities PARTCOM Plus was basically a consortium that was that we had for 6 years, and a lot of different research organizations worked together. A lot of University of Applied Sciences, but also other the Robert Koch Institute. What we basically tried to strengthen was how we can use participatory approaches on municipal strategies for health promotion, and how they can be developed together with the target group and can be implemented. So the field of the research was pretty broad. So we covered children's and family health, but also people with learning difficulties, growing up in poverty, parenting processes, elderly people, and also municipal integration processes and participatory epidemiology. So you see there were quite a few different focuses here. And if you're interested in reading up on this, there's the website that you see here. And a lot of the work, the theoretical work I'm talking about, was part of this research consortium. So when we talk about participatory approaches in epidemiological research, there's a quote that I like a lot, even if it's quite almost 20 years old, but that captures it really, really well. So participatory research is a framework epidemiologists can apply to their studies to gain a better understanding of the social context in which disease outcomes occur, while involving community partners in the research process and ensuring that action is part of the research process itself. So I think this quote highlights what the goals of participatory approaches in epidemiological research can be. So for one, collecting meaningful data to develop recommendations with practical relevance for different stakeholders, for the people we are doing research with, but also for stakeholders and politicians and researchers. Then the mutual transfer of skills and qualifications among the co-researchers, meaning that whoever participates in this process will learn from the other parties involved. So, and I will reflect a little bit more on this when I talk about the study on sexual health in migrants from sub-Saharan Africa. I learned a lot myself. I thought I had a very clear idea of the epidemiological situation on HIV in migrants from sub-Saharan Africa, but I learned a lot about the living conditions, about the environment and the context, the information that I would not have had before. Then, of course, something that is very important is the improved accessibility. So I don't really like the term hard to reach, because I don't believe in hard to reach. I believe in how to reach. So there's a way to reach anyone if we find the proper way, but we need to ask people how we can reach them best, and we need to establish trust. But of course, when involving people from particular hard to be reached groups into the research, we will have better access to these communities. Then also the resource-oriented strengthening of health behavior and health-related conditions of researched population groups. So basically, the focus is not just on doing research, but also changing conditions, changing situations, and improving them for the research group. So what is participatory research? Oh, this didn't work. The animation didn't work, but it's first of all co-research. So the active involvement and preferably equal collaboration or cooperation between researchers and research subjects. I don't like that term a lot, but the people that we want to do research with in individual phases or in the entire epidemiological research process. And I will go over that later, what that means and which steps of the research process I'm referring to here. The goals, again, is, and I mentioned this before, a greater representation of socially disadvantaged population groups in health data on different levels. So on the municipal, states, but also federal level. And
You are frozen. Can you still hear us?
I can hear you. Can you hear me?
Now, yes.
Yeah. Can you also see the presentation?
It says it's gonna be.
You see it like I
soon.
see it.
Yeah.
Okay. So I hope it will be okay. I will just try. I think it should reload. If it's not doing it, we will switch. But you can hear me.
Yes.
Yeah. Okay. Because I think you can still read it. Yeah. Okay. Now it should. Yeah. Let's see. Here we go again. So second, the expansion of epidemiological research approaches through partnership-based survey and analysis methods. So meaning, again, it's a learning process that we enable people also to do research and to use epidemiological research. And the other way around, we understand more about the context. Then strengthening the perspective of socially disadvantaged population groups in data-based recommendations for action. And this is something that's really important. As you know, I work for the German Public Health Institute, and a lot of the times the surveys we do are population surveys, representative surveys, where we want to represent all people who live in Germany. But sometimes we do not cover certain underserved populations, but yet we still develop recommendations. So it's really important when we talk about population-based surveys to also try to include particular underrepresented groups and strengthening their participation in the studies. And that is possible by understanding what it needs to make them participate. So basically, participatory health health research can help to come up with really application-oriented recommendations that we can use and that are important and relevant for all stakeholders involved. So why, I think I already hopefully convinced you why participatory epidemiology is important and can be very helpful to include different populations and to understand their living situation and their background better. But traditionally, this comes from the critique on biomedical individualism or the individualization of risk and poor theories on the connection between exposure and outcome. And it's basically, for instance, when we say people with migration history more or less often access healthcare. This is again an exposure and an outcome. If we look at this closer, we understand very clearly that the migration history does not have anything to do with the utilization of healthcare, but there are different issues. For instance, the duration of stay of people, if people have not been in a country for a longer period of time. They might not know the health system. It might be language skills. It might be discrimination and also racism, experienced racism. So that might hinder them from going to access healthcare. So it is definitely more complex. And we can only understand this if we really include the target population by interpreting the results and by really questioning if outcome and if there's really a causal association. So and epidemiology thus faces problems in explaining the complexity of disease occurrence at various and interacting levels, as we all know. So this participatory research approaches or participatory epidemiology can help us to bridge this gap and understand better the black box, understand better what really happens between a potential risk or exposure and an outcome. So in our research project, we first did, or Mario Bach did this, did a review where he found a literature review where he found scoping review that was published, where he found 7 aspects of participatory epidemiology. And these 7 aspects are oriented when you look at the traditional classic research cycle. So first, we determine the goals. That's the first step, but we do this cooperatively and not as researchers by ourselves. In participatory epidemiology, we develop research questions with public health practitioners and representatives of the population group. Then we determine the study population and location, again, together with cooperating partners. We consider relevant context of the research populations in modeling and the study design. Then we adapt instruments and research methods together. We manage the data collection and interpretation as cooperative projects. So we do not do this on our own. And we prepare data findings and disseminate them in a way that can be used by all stakeholders. So basically, these are the 7 aspects of participatory epidemiology, and I will now show you what this means when applying the study, the study of sexual health of migrants from sub-Saharan Africa to all these 7 aspects. But, oh, this is unfortunately in German. So again, quickly, we look at research goals, research questions, involved in the process, life context of the research group, data collection and analysis, convey the results and use them, and the process design. And this knowledge that we gained here was first, as I mentioned, done with the scoping review, but then also this evolved and we developed it further by discussing it. Because again, if we do a literature review on participatory epidemiology, just as researchers, that is not enough. So we talked with different practitioners here also. So now there's the example that I talked about. So first, again, determine the goals and also develop the research questions. So what we did is when we started with the MISA study, I very naively, I have to say, I invited a lot of different stakeholders to a meeting where I thought we can come up with research questions and a study design. And I had to learn that that was not the case, that there was a lot of skepticism why the Robert Koch Institute wants to do research with migrants from sub-Saharan Africa. And we learned very quickly that this is only possible if we do this together with community partners and with them having the same decision rights than us researchers. So we actually started this process in 2012, so a long time ago. And this slide that I'm showing you is what we discussed about a study design. So we built a working group that consisted of practitioners, researchers, and community partners, but also the Ministry of Health was involved here because they were the ones who were providing us the finances and the funding. So we decided that it's important that they can participate, so they understand that we really need to do this together in a participatory way. Second was that we started with the study design, and the first what we first decided was that this study had to be multi-centered, because we have different we have a lot of different situations in different cities. So a multi-centered study with partner institutions that already had good connections with African communities in the respective places. We also decided that the recruitment of study participants should be done by peer researchers that we would enable to do this and to enable to conduct interviews. What was also important was that we could offer HIV testing, low threshold HIV testing, but that we could not have it be part of the study. And that was something that we really had to convince the ministry of, because they also wanted us to collect blood samples, but the community partners insisted that that was not going to be possible. And so we decided not to do that, not to have it be part of the study. Then what was also important was that when we conduct a study, that at the same time we should disseminate health information through the questionnaire. And I'll show you later how we did this. So we discussed this study design and evaluated it through an additional advisory board. And then we discussed and evaluated the study design with focus groups with different migrants from sub-Saharan Africa. And then we piloted the study design in 2013 in Hamburg with the the AIDS Foundation in Hamburg as our partner institution. And then this is unfortunately this is not the animation is not working that well. Then we had to come up and with instruments and research methods. In terms of the questionnaire, we really developed the questionnaire together with the working group. So we had indicators that we wanted to use from other surveys, but we also discussed about a lot of different questions that might work and might not work. And here it was really our responsibility as researchers to explain why something had to be included and why not. And sometimes, even if I thought it was a very important question, if there was a veto from the community partners, we would not include it in the study. So that was also a learning process for me as a researcher to discuss and be very well prepared why certain things, to really explain understandably why certain aspects are important. In terms of data collection and interpretation, we did this together, and we worked with peer researchers. And I show you this now. The study sites that we used were Hamburg was the pilot, and here are the other study sites. So basically big cities in Germany where we had good access to African communities through partner organizations. Whenever we started the research process in a certain city, we did a community mapping with peer researchers. So this is the one of Hamburg. So where are good spots to find to find migrants from sub-Saharan Africa, to recruit them. So we conducted a CAP survey. CAP stands for Knowledge, Attitudes, Practice, Behavior, with optional HIV testing. And here we used a standardized questionnaire, including informative questions. And what I mean with informative questions is we posted a statement, for instance, AIDS is caused by a virus called HIV, and then people could say, I knew this already, I was not sure if that was true or not, or I didn't know this, or I do not understand this statement. So I think you probably remember that I mentioned earlier that this was fundamental, that if we recruit people, that we should really disseminate knowledge and information on HIV and hepatitis and STIs in this process, because we don't know, sometimes we didn't know if we would reach them again later. So we trained peer researchers to recruit study participants, and initially we from the Robert Koch Institute and some people from our working group did this, and later peer researchers trained peer researchers. Of course, always someone from us joined just for questions, but the training was basically disseminated by peer researchers. The optional HIV testing took place at local public health departments. We made sure that for the time of the study, there was language translation into French and also into English and sometimes other languages, depending on the communities in the respective cities. What we also did was, before we started the study, we talked to local networks of migrants from sub-Saharan Africa, providers of HIV prevention and researchers. So we invited everyone for like a kickoff meeting, also politicians, and we also had meetings in the end to show the results of the study and also to derive recommendations. We did this survey, we conducted it until 2016, and we recruited more than 3,000 participants. So sorry about this animation, that's not working. So talking about recommendations and dissemination, the only thing that we did on our own was the data analysis. We did the data analysis at the Robert Koch Institute, and then went back to the respective cities with the results and discussed in focus groups with peer researchers what these results could mean and what else we should analyze. So that was really, really helpful, because some conclusions we would not have been able to derive, and some ideas for analysis came from community members, and that was really helpful. We then had a meeting in the respective cities, as I mentioned before, to develop recommendations. And we invited also, and that was really important, local politicians who were in charge of the finances for the respective cities and for prevention and care. So, because the idea was that if peer researchers and politicians talk together, that there is a better understanding of each other's needs. And that was actually the case, that in some of the cities, prevention programs were funded afterwards based on the results of the research, of the study. So some of these pictures are from this. I'm just thinking, yeah. One, the picture on the left, in the bottom on the left, you see there's Robert Koch. So that was at the end of the study. We invited all peer researchers and stakeholders from different cities to come together to Berlin to also talk about recommendations that were not just for the cities, but for Germany and for prevention overall in general. So we did this as well. So in the respective cities, but then also for sharing, exchanging different experiences, and also trying to come up with recommendations that are necessary for all cities and for federal basically federal interventions. In terms of dissemination, we had different products. You see here that there was a big report with all study sites, but also there was a study site report in each city that the representatives used also to convince decision makers and politicians. We also offered that an executive summary in French and English, and it was translated by peer researchers. We also had flyers. There are no flyers that to go back into the communities and disseminate flyers. And there were also other, events for community members. We also did, publish just in peer-reviewed journals, but basically there were different ways of dissemination. And that was important to, again, cater to different people's needs. So reflecting on the process, you all have probably seen this pyramid of participation that Michael Wright and colleagues developed already 12 years ago. So when I look at the partner organizations we worked with and our working group, there was really full participation and decision-making authority. And that, to me, was a really big gift to learn with each other and to discuss certain processes and also to discuss things that we as researchers think are given. But that was so valuable to question that and to come up with mutual solutions that worked for everyone. The health authorities and other local organizations were included. Basically, they were informed, and sometimes also, of course, we consulted them, but they did not have decision-making power. So that was basically what we did with the MISA study. Now I want to reflect a little bit on some focus group results. I mentioned that we had a last final big event in Berlin where a lot of stakeholders from the different cities were present. And here we conducted focus groups on the benefits and challenges of participatory research in this study. What worked and what did not work. And I want to share this with you because I find it's very, the results very wise, because it's a better, it's even, I think that the summary is even better, and or I couldn't say it better if I came from, a theoretical background. So what we did is we did 4 focus groups to identify experiences, challenges, and resources, benefits regarding participatory health research in the MISA study. The facilitation was always done by an African community member and a researcher from the Robert Koch Institute using a standardized guide. And per groups, there were always, we tried to divide the groups. So there were always 2 peer researchers or a local study coordinator, a representative of research, public health authority, and federal agency. So we just wanted to make sure that all groups were basically pretty balanced. And we took detailed notes and then did inductive analysis. So the results were general effects of participatory health research is that it produces relevant results for all. And that was something that everyone supported. There was a better understanding of results. There was a focus on the population under study and their living or life situation. And this helped to establish local, regional, and federal networks and collaborations, and in building partnerships and trust. So this sounds all that were general effects, and they were mostly positive. Then we asked, so what about the utilization of peer research? And they said well, what was said was, yeah, that's really helpful because we reached particularly vulnerable populations, subpopulations. We, with peer researchers, we have potential multiplicators that can go and do prevention afterwards. Helpful for empowerment and community building and mobilization. And a good reputation within the community was established. But there were also some challenges. So, and some of them are particular to the MISA study. Why was there a focus only on migrants from sub-Saharan Africa? The length of the survey, it was too long. Some of the topics, because it was sexual health, were too sensitive. It was resource intensive, and limitations of participation. And it, in particular, two challenges to me were pointed out quite a few times. One was the expectations. With doing participatory health research, you create expectations in the community. And if you conduct a project and it's done and you cannot continue doing this work, that can be very harmful because people expect you to continue to help, and you need some time for implementing the results, and you need to continue to support community members. We tried to do that. For instance, we tried to go to conferences, also to scientific conferences with peer researchers together and enable them also to do presentations and scientific talks, but that needs more time, and we did not have enough time. And that goes hand in hand with sustainable implementation. If we think of conducting participatory health research, we need the finances, the funding, and also the time to implement basically the interventions that or recommendations that we came up with. And we did not, or only partially, had enough times. And so some of the cities where there was already strong networks and good connections with public health authorities, projects were started, and that worked well. But in other cities, that was not the case. And that's something I definitely learned, that we need more time. Then also, the conclusions were utilizing participatory health research and epidemiological research works because it's a valuable tool to improve accessibility and to get a broader perspective on the generated results, as I mentioned before. Participatory health research as an approach was supported by all relevant stakeholders because it gave us good access to the African communities and improved the acceptance of the study among the people we conducted the research with. But we have to think ahead. So I mentioned this before, but I cannot mention it often enough. It is crucial to consider sustainable structures that last beyond the research process. And I'm afraid this only happened partially with the MISA study. So concluding, why should we still, if there are some challenges, why should we include at least elements of participatory health research in epidemiological research? Well, of course, the improved field access is helpful, but also to develop practical questions that people want to answer, to understand better how to reach the so-called hard to reach, to develop accepted instruments and methods. So we, for instance, in other research studies where we were not able to go all the way with participatory health research, at least we would try to develop instruments together or to have them validated by community members to make sure that they work for everyone. Then, of course, building competence competences among the participants involved, learning from each other. That to me is so valuable, because I have to say, whenever I think about this study, I have never so closely with so many people that I slowly established trust with, people that I did not know before, but we really try to do this together. And so I understood much more about the situation, about discrimination, about racism in African communities or against African communities, all these things, just getting first-hand information, talking about this and being open and transparent in this process was very valuable. And then, of course, conveying and disseminating results in a way that everyone benefits from it. And as I mentioned before, super important, sustainability, looking at potential stakeholders and networks that can carry on the work. And we had these networks in the MISA study because the German AIDS foundations had some networks that would carry on, but also investing at least half a year to really help this transfer of research results and recommendations into practice, and evaluating in the long run if these recommendations were really what we needed, and if the prevention measures we came up with were what helps community to, or health issues to be tackled. So thank you. This is the last one. This is basically a small summary. So participatory health research, when we look at epidemiological research, we do research, we come up with scientific results, we develop specific measures in health promotion and prevention, and then this goes to the researched and practitioners. But then, ideally, from people, from the populations themselves and from practitioners come new ideas and issues that should be tackled in epidemiological research. And then we get to scientific results. You see, that's a circle. So concluding, participation in epidemiological research is possible, and it is also necessary to get a more complete picture. And so I thank you very much for your attention, and I'm sure you have some questions about, some, maybe also some of the experiences I shared. And thank you so much. And let's see what your questions are.
Oh, thank you very much for this presentation and the insights you gave, both up in defining participatory epidemiology, but also in carrying it out and hinting us at the potential pathways and pitfalls all along the research process. There are already some questions in the chat if you want. So the first one was by Theresia Krieger on, she had a question early on or in the background part of the presentation to step 5 of the circle, adapting the instruments, and she asked whether new instruments were also included. I don't know whether you want to add on that a little bit. What kind of instruments did you develop with the groups?
Yeah, I can definitely. So there were some indicators that we used from the ECDC, the European Center of Disease Control and Prevention, and we tried to use instruments that were already implemented in other. For instance, the baseline survey on African communities, but there were some where we had to come up with complete new instruments that were not existing before, and then we would we did cognitive testing also. So first we came up with ideas, we consented it in the group, and then we would go and work with some peer research and make sure that whatever we were asking was also understood. So working also with cognitive testing in this process.
Thanks. Another question by Peter. Peter, do you want to unmute yourself and and ask your question.
Hi, congratulations on your presentation. I think participatory research for me is very new. So I think my question, maybe it's very naive, but could you do an interventional study design using a participatory approach?
That's a very good question. I think it depends. Do you want to give me an example? Maybe what exactly, because I think it depends a little bit on the situation and on the goals of the research and what kind of intervention it is.
Currently, at the top of my head, I have no idea, but maybe like, for example, as a follow-up on your study, if you see like a possible intervention, how would you do it in a participative way? For example, in your observational study.
Like, for instance, if we had a certain prevention measure and we would implement it, and I think that's a good question. I think what you could do is have, probably now from the top of my head, definitely have a working group that with community members, again, to come up with an evaluation, like a way of how to evaluate it. I mean, of course, we have certain steps that we have to follow in evaluation, but still, I think in this case, or that's something that I learned also from community, that the criteria that we have is sometimes not sufficient, because it depends also if we want to see if an intervention works. We can look at whether if it changes health, but we could also see if it's accepted. So I think coming up with the different indicators and ways on how to measure or how to evaluate, that's something that is could be done with practitioners and also community members. And so I think that is possible. But if you want to, if you're interested and if you're working on a particular study, maybe we can talk some more later. And I think a little bit more about that, because maybe that would be a good idea.
Yes, I see Nicola Loh put on the screen, so maybe you want to, you have a question as well. And I would like to take the chance just for a minute to advertise the upcoming lectures in fall, because one of them actually has the focus on participatory research in intervention another one will focus on participatory research in evaluation of interventions. So there might be more answers coming in on those aspects. But Nicola, please go ahead.
Thanks, Annika, and thanks, Claudia, for that really interesting presentation. I wanted to come in and make a couple of comments. One is about how you ended up doing research about sexual health in migrants from sub-Saharan Africa in Germany. And really, from the point of view, this sexual health and sexually transmitted infections are what I do for a living. And we had a project that it seems in a way quite similar to a project that we had called SELMA, which is called Sexual Health of Migrants and Asylum Seekers, and our focus was in the Middle East and in Pakistan. So and I hadn't heard of your project, so I'm really, really pleased to hear about it. I had a comment for Peter, and then I'd like to ask a question. So my comment for Peter was that the kind of thing that you're talking about, I think is or maybe this is a question too, is actually there is this thing that is called patient and public involvement in research. So if you are doing research in the UK and you put in a grant proposal and it's going to be publicly funded by the National Health Service, you have to say in what way you are involving patients and the public in your research. And for example, in a intervention study that we just did, a cluster randomized controlled trial about contact tracing for sexually transmitted infections, we had there is a patient and public engagement panel for sexual health studies. And at each stage of the research, the panel was involved in saying whether they thought that the question was appropriate, whether they thought the materials that we were using were appropriate. We could test our materials on them. So it is very much expected or increasingly expected, I think, in intervention research. If you submit a publication to the British Medical Journal, you have to say, and it's a clinical study, you have to say in what way you have involved patients in the public. And if you haven't, you have to say why you did not. So I think it is, it's increasingly becoming a part of what's expected. So my question about the participatory research, which I also posed to the previous speaker in this series, is one about at what stage that your participatory approach starts, and what do you do if your participatory, your peer educators talk to your communities and they decide, or they tell you that they're just simply not interested in your research question about sexual health. What they would much rather you investigate is why is it that, for example, they have little access to benefits, because this is what is most important in their lives. Would you have changed your research question to investigate access to social security benefits?
Thank you. So first, why did we conduct this study on sexual health in this target population? That was simply due to the HIV epidemiology in Germany, where migrants from sub-Saharan Africa are one of the groups that is mostly affected, besides men who have sex with men, the classic other risk groups. And so that's why we started this process. Well, and I thought that was convincing. It might be convincing enough for community members, but it wasn't. So that is a very good question. So I presented proudly my epidemiological, graphs, and they said, yeah, so what? Mm-hmm. But basically, what was really helpful was that the community members we worked with, most of them were already working at either AIDS foundations, public health authorities, and they did understand that, well, for one, HIV, but also in particular, hepatitis B and C were extremely important topics to address. And so what we did, they said, please don't label it as an HIV study. If we focus more on hepatitis B and C, that will work better. And then we can continue with this process. And let's call it a study on sexual health because, that's more general. So we were lucky. And in terms of your, regarding your question, if people from the community had said, social security benefits are more important to be addressed, we could not have done it because we would not have gained funding from the ministry for that, because that was the department, that was in charge of sexual health. So then we would not have been able to conduct the survey. So basically what we did, and I didn't mention it in detail, but we had a phase of like half a year where we did a lot of background research and talked with a lot of community members and try to figure out whether this topic could be addressed in a survey. And well, in the end, they said, we think it's possible, and there is interest in this, in communities. And if we label it in a certain way and we make sure that the questions are asked in a certain way, then we are okay with it, and we can, continue with the research. But otherwise we would have not been able to, which is sad, because, we should be, because true participatory, well, that's what I would like to do. The question should come from community, and it should be whatever is important to community. And I'm sure sexual health is not the most important topic. And that's what they even said, that sexual health is important, but also mental health was a topic that was mentioned, or, post-traumatic stress disorder for people, who escaped wars or, crises, for instance. But we were not able to include that in the survey. So that also caused some frustration. Yeah, but that would be ideal if you were completely open from the beginning and would start with working with community, open-minded and without your own agenda. But we had a little bit of an agenda, and otherwise we could not have done it. But we were transparent about that from the beginning, so it worked. Yeah.
But doesn't that sort of reduce trust in research? Because then you'll have people in the community say, well, we told them that this is the most important issue for us, but they always ignore us. So the state isn't interested in us, researchers aren't interested in us.
I think it depends. Well, for us, the peer researchers were convinced that this is a study that helps as a first step towards, empowerment and trying to find out what community really wants in this topic, so they saw it as a chance. And I think that helped. So the community partners and the peer researchers really, they were convinced that this is something beneficial. And so they kind of transported that into community. And so that worked. But I agree, it could definitely be that and I'm sure that some people said, why sexual health? That's random, because that's not really our, that's not what concerns us, or that's not what's the most important thing on my mind. But it did work in this context. But I'm sure in general, coming with a more open mind and being able, just having a population that you want to work with and then determining with them what is the most important topic, that would be, an ideal way. But we weren't able to. Yeah.
Yeah, thank you. So maybe following up on this issue, I would have a comment and the question. So as a comment, I guess you nicely pointed out and also showed the ladder of participation, and I guess what needs to be acknowledged and be also transparent in participatory health research really is that there is a level of participation among community members, and that we often have peer researchers or stakeholders and community members who really are peer researchers and into shared decision making, but also those, particularly if it comes to participatory epidemiology, we have study participants who are informed but would not take part in decision making, and of course there might be a higher distance and the concrete study might be of less importance to those groups, but it's about really the shared decision making with the stakeholders from the community that might make the difference. And also my question is kind of related to that. The question would be, what is in your perspective the main difference then between community-based participatory health research and participatory epidemiology? Because I think one advantage of community-based participatory health research would be it's always located in the communities and in the life worlds of the people, and could take up what Nicola just mentioned. If the focus would be something else, you would have the network and stakeholders who could take care of the social security issues and start a project in this field while you carry on or not carry on the study topic as planned. So, but maybe you could tell a little bit from your perspective whether you see any difference between participatory epidemiology and community-based research.
I think, yeah, I see a difference, and the difference is that I think that a community-based participatory health research is more community-based than participatory epidemiology. And as I said, that in participatory epidemiology, we even consider it partially participatory if we only utilize participatory approaches in one or two steps of the research process. And I don't think that's not. Of course, it's not 100% participatory research, but it still helps, to understand, to get a better understanding of the perspective of the researched. And a lot of you probably know, for epidemiologists, for people who work I mean, I don't want to stereotype epidemiologists that they're like that they do not consider the people's points of views, but I remember from my experience also at the Robert Koch Institute that there was a lot of confusion about why is this important. We do, we calculate our models and we see associations, and then we can't necessarily, we can try to interpret them with the literature, and that's what we do. And trying to explain how important it is that we can't always do that, and that it's important to also see the perspective of the people we do research with or on, how they would say, I think that's hard work, but slowly, step by step, it's changing. And so I think participatory epidemiology is less participatory than community-based approaches. But ideally, I think it is possible that a participatory research study could be community-based if you really start in the community with the research questions and developing and basically have the community give the idea of, okay, we need you researchers to help us with your epidemiological expertise. So yeah, does that answer your question?
Yes, thank you.
Okay.
So I look around among participants. I don't see a raised hand for now, and also checking the watch and honor the time of everyone who showed up. If there's no urgent issue to be discussed right now, oh, there's one. Okay, so Christopher, first question. So we will close with those two questions. Would there be the possibility to share the data which indicates towards more important research topics from the community with other researchers? Could you do that? And were there different understandings of healthcare? And if so, did your understanding of healthcare change during the process in the project? Maybe you can comment on that as well.
Well, for number one, I'm not sure if we documented all of that, but I can look. I can share in the report. I think there is a chapter on this, and that's on the website, on the RKI website. So you can just type in my MISA study, and then you'll find it. In terms of like, were there different understandings of healthcare? Well, there were definitely different. Well, what we discussed a lot was access to healthcare, because in our study we included quite a few participants without health insurance, and so they did not have access to healthcare. And we discussed a lot the barriers. Well, the legal barriers. We also discussed other barriers to healthcare, and in particular, again, sexual healthcare. But yeah, there's also an article about that is also available on the website, was published, where we looked at people who were not insured or did not have health insurance, and the differences in their perspective. So maybe that helps. But definitely, I understood a lot more about the possible barriers to healthcare, especially to sexual health services, because we discussed this a lot, and this is also included in the final report.
Thank you for elaborating on this, and thank you all for showing up and asking the question and enriching the discussions. And so for today, I have to say thank you and goodbye, and have a good afternoon. Thank you for joining us in the lecture series. Yeah. Thanks again
you
to you, Claudia.
Yeah, and thank you all so much for your questions.